Menrva Lounge. Great to see you after a wonderful 4th of July weekend. Joined by Dr. Betty, co-founder of Menrva. I'm Kelly Resendez. And we're going to dig in today a little bit to research around women's health in comparison to men's health. And it's something that Betty's very passionate about. And if you could just start a little bit, giving us a general landscape of the lack of research that really has occurred in the women's health space.
Yeah. So, for those of you that are on this call or listening to this call later on, and if you've listened to me before, you might know this stat, but I think most women are surprised to know that women, number one, were left out of medical research, right? Medical research until 1993. So that means actively removed from or not included. They were on the exclusion criteria for clinical trials with medications and other things. Now, this is for multiple reasons. The primary reason is they didn't want our pesky hormones to get in the way or confound the outcomes they were looking to test, because they knew that our hormones affect every part of our body. There was also a prevailing opinion that women wouldn't be able to withstand the rigors of studies. Right? Now, we have to remember that lobotomies were routinely performed on women who were in menopause and perimenopause. In the day, that was actually what the treatment were. And I forgot what the number was, but it was like 30,000 women, at least on record, are known to have had lobotomies for being, ill-behaved, and most of them were in midlife. So it's not surprising to see that, there was kind of this prevailing opinion that women couldn't handle the rigors of research. But it was really the 1993, we had to legislate the inclusion of women in research, particularly clinical trials. And that's really what brought about the Women's Health Initiative, which basically, if you haven't heard that study, but I think every woman has, was basically the study that took hormone replacement therapy that was standard of care since the 40s and took it off the map basically for women. That has largely been, disproved through longitudinal studies of the same individuals continuing to follow them, and then also, current research, and we don't even use those type of hormones anymore. But I think some of the even more shocking numbers are what's really spent on women's health in general. So women as a whole, if you count all females, we get about 4% of all research dollars. However, when you get to women over 40 and we get past fertility, so if you take out breast cancer and fertility, women in menopause and any kind of menopause related or older age related, decline in women's health, we get less than 1% of the research dollars worldwide. And I was looking at some of the data over the weekend, kind of looking at it going, okay, I would expect us to be in a better place, but erectile dysfunction, of which we have over 17 medications for, it affects 19% of men, worldwide has received up to date $2.8 billion in research dollars. Now, when you compare menopause, worldwide, we've received less than 300 million over the course of all these decades. And it's 100% of women go through it. It's 51% of the population. And it is the largest arc that causes a significant increase in the risk factors for things like cognitive decline, Alzheimer's, cardiovascular disease, osteoporosis, because it is a full body event. And I think if we called menopause what it really kind of is, which is a full-on castration of our hormones, our sex hormones, because essentially our ovaries stop working. Men never experience a full testicular failure, right? They have decline over time, but generally speaking, men don't go through that in the aging process. And it's not because it's intended to do so. We believed that it was the loss of ovarian function. So think of it as it's a carton of eggs, and it's when the eggs run out. Well, I don't know about you, but it has only been in the last 15 years that I understood that every single month, like when you were cycling, every single month, generally one egg popped out. Some people might have had two. That's how you get twins. But we lose 1,000 eggs on average every month. Even when we're infants, we're losing eggs constantly. So we have millions upon millions of eggs. So one egg survives and makes it out, but 1,000 of them attempt to go to maturation and don't, and we lose all of them each time. So there's a lot of research going on. A woman that goes by Boss Ovary online runs a company that is looking at how can we preserve ovarian function? Like how can we keep from losing all those eggs over time? But I think if we looked at it like that, like it's all of a sudden the castration or the removal of ovarian function completely, and compared it to castration on a man, I think everybody would take it more seriously.
Yeah, wow. It's absolutely incredible and shocking. And what would you say we need to do? Like what would be the solution so that we do have better research for women?
I think it's multifold. I mean, some of it is, we've always depended on NIH, or if you're in England, NHS. We've always depended on the funding of government funding to fund universities that do these studies. But we have a lot of unrest going on in the United States and a lot of dismantling of the science structure that has enabled us to, fund research. Like we have entire cancer studies that were halted just because they were like, nope, politician gets to make those decisions today. And right now there's some legislation that's up for debate on whether politicians get to decide what studies actually get funded. Right. And so when I look at that, and whether you're a perimenopause or menopausal woman, or a woman that's not there yet, or even a younger woman, the way we make a difference is that we get involved in research, right? That we get involved either being part of the research study, helping fund research studies. So private industry can fund research just like, NIH and all these other organizations. We just have to find ways to get behind organizations, whether they're universities or Melinda Gates, and help push this agenda forward. Because my argument is that not just that we deserve better, we need to demand better. Because I don't know about your parents. My parents were kind of hardcore, Gen X. We were kind of feral children. Mom and dad were kind of do what you want to do. But the truth is, my parents said, you rarely get what you deserve. You get what you demand. Right.
Yeah.
And so I look at that and I go, yeah, we deserve more, but as women, we should be trying to figure out where we can demand more.
Absolutely. Absolutely. So let's kind of switch topics a little bit to estrogen
Yeah.
and talk a little bit more because so many of us, don't really understand where estrogen is in our bodies. We think about it as being a sex hormone only,
Mhm.
but given it protects us in so many other areas, explain a little bit where estrogen is in our bodies.
Yep. So here's what happens in your body. So you get messengers from your brain, right? There's the pituitary and the hypothalamus. Think of those as your director of your show and your conductor. And they send out messengers to your organs that produce hormones. So like the thyroid, the adrenals, the ovaries. And they instruct them to either increase or decrease particular hormones based on what the body needs to do, whether it's kind of turn up the metabolism, or get an egg to come out of the ovary so we can try and continue the human species. And so those messengers are the main conversation pieces. So one's called luteinizing hormone, the other one's called follicular stimulating hormone, and FSH is the one that talks to the ovaries. And FSH, when you're normally cycling and your eggs coming out once a month and you have a cycle, it is very, very quiet, and then it gets very loud to tell the egg to do what it needs to do. And then it quiets down again when you have your period. Well, when you no longer have ovarian function because you run out of eggs, what happens is those messengers get very loud. So they're very high. Like if you look at them in the blood, they're very high. Because what's happened is your ovaries actually take testosterone. So your ovaries make testosterone out of a raw material called pregnenolone. So pregnenolone comes down and can make a bunch of different things. So think of that as it's kind of like flour, right? You can use flour in all these different things like bread and biscuits and cookies. So that's the raw material. And then each time you make a different hormone, it's a different thing, a biscuit or a cookie. So pregnenolone inside that organ goes through this process and eventually makes testosterone. And then eventually that testosterone gets converted into estrogen in the ovaries. So testosterone is the precursor to your estrogen, right? Always. And it can also be made in your adrenals, but at much lower levels. So we make smaller amounts of it in the adrenals. Your fat cells also can take testosterone and make it into estrogen. And that's probably part of the reason why we see weight gain as part of the mechanism for a lot of women during menopause. Is there's probably a piece of it where the body's like, hey, I'm going to help you with some estrogen. There's also a big metabolic effect that we've talked about before. So the ovaries are a primary production of estrogen from testosterone when we still have function. However, testosterone in a total volume is more in our body at any given time than the amount of estrogen. So here's a way to kind of look at it. This is how much testosterone your body makes. Oh, it won't even show the pic. Yeah, this big Stanley cup, right? A big Stanley cup is the amount of testosterone your body makes. And then this little tiny thing that's much smaller is the amount of estrogen to it. So it's the equivalent of saying like quarts to cups, right? So we have a lot of testosterone circulating, gets made into estrogen. And then estrogen basically drops off a cliff, right? Because the ovaries don't have eggs anymore. We don't have that mechanism to drive the production of estrogen. And then at the same time, because the egg doesn't fly out, we don't make progesterone, because it's actually when the egg flies out and everything sort of collapses. So think of it as like a sunflower that dropped its seed. When that sunflower collapses, that's what makes progesterone. And that's why everything fails. So for women, it's primarily made in our ovaries. And when we lose that ovarian function, we don't make enough in our adrenals. We don't make enough in our fat cells. We don't make enough even in our bone, because testosterone gets converted in bone, but at much lower levels, to make up for what's missing. And so the other really important thing is the volume of estrogen isn't that much, but the amount of receptors. So think of that as the keyhole that estrogen clicks in and turns on the engines everywhere it clicks in. We have truckloads, lots and lots and lots of estrogen receptors. We have a lot less testosterone receptors, right? And so when those receptors or those keyholes don't have estrogen anymore, it becomes a full body effect. It's not just we're not able to procreate anymore. It's everything starts to change, because every cell in the body, except for two, has a keyhole for estrogen. So estrogen is lower in volume to testosterone, but higher in impact because of the number of receptors.
Yeah, so what are some of the major symptoms somebody experiences that maybe you wouldn't think of, that when your estrogen goes down are affected?
Yeah, I think one of the most insidious ones are the things that we get told are aging, right? Joint pain, right? Hands, wrists, hips, tendonitis, bursitis, right? Some of these things that we're just like, oh, my knee hurts, my hip hurts, my butt hurts, my elbow hurts, like all of those things. And it's the technical term for it is a musculoskeletal syndrome of menopause, but it is because all those parts have receptors. And when they aren't working, they get dried out, they get crispy, they get frayed. The lubricant around it starts to dry up, dry mouth, dry eyes, things dry out. Your skin. Like I had very thick, kind of oily skin until I hit sort of the tail end of perimenopause. And it was like all of a sudden, what used to be really oily is like Sahara Desert. I have never spent so much money on creams and stuff like that, because the skin dries out, the collagen production dries out. And so a lot of women too will start having joint pain where they lose the kind of buffers, between the joints, like the knee pad that's made from collagen and cartilage and then the lubricant around it. So even things that are like parts of your body start to ache, hurt, break apart or break down a little bit. That's not just aging. That is the loss of estrogen, and estrogen slows some of that when you put it in. I think the other thing that gets missed a lot, because we get told hot flashes and night sweats, but the earliest symptoms, and this is backed up by research that was produced by Flow, one of the apps that people use to track their symptoms for fertility. And what they found was a third of women that are in their 30s are experiencing what we would call menopausal symptoms already. Right. And what's interesting is the early symptoms are things like brain fog, fatigue, irritability, anxiety, depression. They're neurological, word finding issues. It's neurocognitive stuff that shows up before the hot flashes and the night sweats. But we often think, oh, I'm tired, I'm not sleeping well, which is often, kind of those other symptoms as well. But we chalk it up to things that we call aging, when it really is part of that hormonal pattern that is also a part of it. Maybe not for everybody. I mean, I definitely know women that are like, didn't have any of that. I'm like, oh my gosh, thank God you're an outlier.
Yeah, definitely. What about your heart?
Yeah, so heart is another one. So heart palpitations are extremely common in women in their 40s. And so what that means is you might be sitting on the couch and all of a sudden the heart starts beating fast for no reason. You're not doing anything, or it feels like it's tap dancing, right? It'll be like, dun-dun-dun, like it's not a normal beat, or you feel it more strongly. That is completely associated with the loss of estrogen, right? It's a perimenopausal symptom, and it can continue. But for a lot of women, it's really scary, right? So you think you're having some sort of heart event. You go to a cardiologist who's had zero training in menopause. They do a full workup, EKG, stress test, a bunch of labs, possibly go, do some imaging. And then they come back and they go, oh, it's anxiety. It's like, no, it's estrogen loss, right? And it's because the nodes, so your heart has electronics that go to it. So think of it, it's got a bunch of electrical plugs in it, and it's what causes it to move, right? And what happens is those are estrogen sensitive. So you get one that's kind of like, and it's out of sync, right? And it'll go off. Now you can have significant ones like AFib, which is a cardiovascular concern that is not estrogen driven, but most people just get where they sort of get agitated and they get out of whack. And then this is made worse by things like caffeine. So if you're not sleeping, you're agitated, you're tired, you're losing your estrogen, your heart's racing, what are you probably doing? You're probably using coffee and caffeine to keep you going, which is going to exacerbate it and make it worse. But a lot of women, that gets missed, and they end up having a workup that excludes their hormones, rather includes the hormones, which is probably what's driving the vast majority of the symptoms.
Yeah. So for the woman that didn't have any symptoms, or maybe is beyond symptoms, that hasn't explored hormone replacement therapy, what are the benefits? And is there a too late point in which you should
Yeah.
just not consider it?
Yeah. So what else I will talk about first is where we know that there's good indication regardless of age, right? Osteoporosis, osteopenia is the strongest indicator that it doesn't matter how old you are, hormone replacement therapy can help, right? We have studies. There's, I want to say it was called the North Star study, that used a very low dose, like extremely low dose, like not one that we would consider for the treatment of any other symptoms because it's lower than what would actually make a difference. But that study looked at older menopausal women significantly outside of the window and using the patch at a really low dose of 0.0175, which again is incredibly low, and showed that there was a statistically significant change in bone mineral density. Now, was it astronomical? No, but it was enough to be statistically significant. So it was not by accident or chance. So if we're looking at somebody that is trying to assess osteoporosis risk, and particularly fracture risk, estrogen was approved in 1988 by the FDA for the treatment of osteopenia for the reduction of fracture risk, right? So it actually does what you want it to do, which is improve the risk for fracture. Bone density does not equate to fracture risk, actually, right? Less than 5% to some degree. Just because it's denser doesn't mean it's actually stronger. And so if I were to look at the one thing that I would say, you know what, if this is the high risk pattern that we're concerned with, right? If we were to I think this is, it's anytime you do some sort of treatment, there's always a benefit and a risk, right? And so I look at it as almost like an accountant. I'm adding up all the positives and I'm adding up all the negatives and I'm weighing them against each other. But if osteoporosis and loss of mobility and freedom is way up there on my list, regardless of age, I might really look at it more strongly then, even though I'm not symptomatic, right? Now, when we look at the cardiovascular and particularly the dementia, Alzheimer's risks, we know now that introducing hormone replacement therapy, particularly in the form of what we use today, which is topical estrogen, topical testosterone, oral micronized progesterone, not synthetic progestins, given in that first 10 windows of menopause, so in that first decade from menopause, has the best preventative support for the heart, the vascular system, and the brain. We don't, from older studies, and again, most of this is from the Women's Health Initiative when they've gone back and sort of mined the data after the fact. We don't have good data if it's introduced, let's say at 75. Right? Because a lot of what's happened in the body, the vascular system has changed because of the loss of estrogen, because estrogen acts kind of as an antioxidant and anti-inflammatory in the arteries, right, and veins, and they help it recover and rebuild. It lowers cholesterol because it acts on the liver. So all these things that we know are vascular risks, that accelerates when we've gone through menopause and we weren't on hormones because we were told we couldn't, right? But that window seems to shift, and we don't see a reversal of that on the data that we do have, right? So we don't see adding hormones at 75 reversing us backwards to, let's say, a 55-year-old vascular system. Same thing cognitively. We know that the brain goes through some significant remodeling. Doesn't mean everybody's going to have memory problems. It doesn't mean everybody's going to have dementia, but we know that we see a reduction in the powerhouses, the mitochondria and the frontal lobe. And it's sort of think of it as the gas is sort of slowed down a little bit, so you're not firing on all cylinders. We see a changing of the mapping of the neural pathways, particularly to like the memory and cognitive areas. But what's interesting is over about a decade, that sort of shifts and it maps differently, and a lot of those symptoms and everything go away. So it's not that it's complete change. It's that a lot of what it was relying on before that was really powering this sort of executive function is not as well powered as it was before. We don't have data showing that if I'm 75 and I start it, that we're going to reverse that. But it doesn't mean we're going to make it worse either, right? Yeah. We do have oral studies. So let me clarify that too. We do have oral studies with Premarin and progestins, synthetic progestins, increasing risk of vascular concerns in older women that started way later. And it's because one, synthetic progestins, they increase clotting risk in everybody, but especially when you're an older woman. And then the oral estrogen gets metabolized into a bunch of stuff in the liver that is less favorable, and it may increase the vascular risk. So topical forms, I look at the research and I go, okay, somebody might be 75. We may not see this dramatic improvement in these other areas, but we might be able to preserve the bone and they might feel better, right? Genital urinary syndrome, musculoskeletal syndrome, they may see improvements in those things. We just don't know that yet, but they may, so they may have benefit even if we aren't in those windows of perfection that we know today. And that's even perfection. That's why I'm air quoting it. The best case scenario is in that first decade.
Yeah. So share a little bit more on the difference between bioidentical and synthetic.
Yeah. So bioidentical and synthetic hormones are synthesized in a lab, right? Now, the bioidenticals actually are derived from plant sources, right? So they're derived from plant sources, and in a pharmaceutical environment, they are at concentrations high enough to raise your systemic levels. The over-the-counter stuff is not. Think of it as I showed you kind of the example of the Stanley cup and then a little cup. So the stuff you can get over the counter is kind of like a tiny little lip balm, right? The dose is very low. So when we look at bioidentical hormones, what it means is that what was synthesized in the lab is chemically identical to the hormone that you made. So if you think of the hormone as like a key and it's got, 5 fingers on the key, when they make it in the lab, it has the exact same 5 fingers. So it's like you took that key to Lowe's and made a copy of it, and it's an identical match. When they're synthetic, there's always something different about it, right? Synthetic means that it sort of fits the lock, but not really. There's multiple reasons why we do that. Sometimes, like in the case of birth control, we do that so the key gets into the lock and breaks off in the lock and doesn't let go, right? Because birth control is intended to keep you from ovulating, right? So it irreversibly binds to the keyhole receptor, right? And that's how we can ensure that you're less likely to get pregnant or almost impossible to get pregnant, right? That's why they're synthetic. But synthetic, because they are different, they can increase risk on the other side too. So they can cause more symptoms because they don't operate 100% the same. And that's what we see with medroxyprogestins, which are what was used traditionally in like PremPro, and that was the risk factor with the Women's Health Initiative. But there are other progestins like what's in a Mirena IUD that people might be on in their 40s because they're also potentially still fertile, right? Doesn't mean you can't do a progesterone that's bioidentical, but you want that synthetic to provide the birth control that you need, right? So we don't have bioidentical forms of that. And then the other thing that's really important to understand is particularly with estrogen and testosterone, we generally don't do that orally, right? And today you can have an estradiol that's bioidentical. So if it says estradiol, it's always bioidentical because that's the actual name of the hormone. And then you can also have what we call biest, which is estradiol with an estriol, which is a really weak version of estrogen, but it has a preference for the keyhole that is protective called estrogen receptor B against proliferation, right? So estradiol has a place. And those are given topically. in most cases, because then it doesn't go to the liver first, it goes straight to the bloodstream, does its work. Premarin was given orally, and it increases the clotting risk because of what happens in the liver. So when you're looking at bioidentical, it really is chemically identical to what you make, regardless of how it was made. And generally, the application is going to be topically, either cream, a patch, an oil, or injectable underneath the surface of the skin, but it's not something you ingest. Although some prescribers will give oral estradiol. And here's where it gets interesting. Oral estradiol has research that it shows that it reduces cholesterol better than topical estradiol, but it has that first pass liver metabolism, which may later on be less favorable. So some people, particularly if somebody went into, like, let's say menopause very early, or had, medically induced menopause early because they've got a hysterectomy, a lot of times they'll use estradiol to begin with orally because it's easier to take. But I generally don't think, we don't have enough research to say give it to somebody else that's a lot older.
Got it. I'm going to have you explain a little bit on a hormone that a lot of people don't talk about, yet we prescribe DHEA, and kind of why we do include that in the hormone stack that we prescribe.
Yeah, so DHEA, dihydroepiandrosterone. So DHEA has two forms. DHEA when you're testing it in the blood, DHEA and DHEA sulfate. DHEAS is the active form, meaning that is out, it's out of a taxi cab, and its job is to go support the stress response. So DHEA's primary role is to respond to the elevation in adrenaline and cortisol, right? So it is the protective hormone that jumps in and says, nothing to see here, calm down, we need to go rebuild, so rest, restore, relax. It is also the precursor, or one of the precursors, to testosterone and some other hormones that are androgens called androstenedione, androsterone. So it is the parent and part of the androgen stack, which are our rest, restore, recover hormones. And all women have them, right? They outnumber estrogen again. We just don't have as many receptors for them like guys do.
Okay, got it. So it's important. Does it also protect you against aging?
Yeah, I mean, it is one of the hormones that declines with significant stress response. So if you've been like most women and you spent the last 3 to 4 decades on the stress train, your DHEA is likely declined, right? And so it is one of the things that supports muscle building, recovery, sleep quality, mood. We have science that shows that in some people, it can even lift mood, right? And so it's part of what we look at, because you can't
Yeah.
you can't look in the hormones in isolation. They all play together.
Yeah, definitely. Definitely. Well, I think we're going to end today and open it up for Q&A. So thanks to all of you guys that listen. Make sure that you share this with a friend, come back and join us. And we're still working towards getting the Get Hormones Now platform up and running so we can support all of you getting optimized. So thanks again.